So I just kind of picked some random images I found in the drive and that I thought looked kind of interesting, and we could talk about them.
Okay, now let me see. I have access to the pictures. I could start sharing them. And let me just do that. So let's first welcome people. So hello, everybody. It is 4 o'clock. We missed one of our case reviews because we were on way to Oman, but we are back and we are going to talk about some clinical pictures related to the spine. And we have Christina here, we have Amanda and Mike with us here today. So welcome to our clinical case review. Now, Mike, why don't you and I start with what we see here?
And I'm going to actually just leave it up to Mike. He has all the clinical knowledge.
Excellent. Yeah. Well, so Mike.
And Neil says he's in the waiting room, just so you know.
Let me see. Can somebody else take ownership of that? Maybe even I make Neil to admin so that he can as well help us with the managing the. So let's see.
Hey, Neil.
Hello. How you guys doing?
Good.
Have a good case review, guys.
Okay. Neil, I'm going to make you host so you can admit people and answer their question. And so you're host as of now.
Sounds good.
Okay.
Okay.
So let's start with this picture. First of all, if you remember, any clinical description of a picture starts with the identifier of the patient. Obviously, we are not going to do that here. But then the next step is identifying what kind of picture we are looking at. Now, Christina is here, so why don't we start with you, Christina? Let's start. What kind of picture are you looking at, and describe what you see? First of all, what kind of modality are we looking at? You guys know what the modality means, right? Ultrasound is a modality, X-ray is a modality, CT is a modality, and MRI is a modality. So go ahead. What do you see?
I would say is the CT.
Correct. It's a CT of what area of the body is it from?
Is this the lower lumbar spine?
Well, we generally, first becomes the modality. It's a CT of the lumbar spine, correct. And then just looking at that, it's a little cut off. I'm assuming Michael cut off the lower part to get rid of the identifiers. But I'm just going to assume and tell you that this is the sacrum, probably sacrum. And then 5, 4, 3, 2, 1. So it's a CT of the entire lumbar spine.
Okay.
Okay. So what else do you want to say about this to identify what it is?
I would also say is this a lateral view of the lumbar spine?
Yes, but we don't call it a lateral view. It is a lateral view on the left, but there is a different name we used to call it it's same like lateral, but
the sagittal view.
It's a sagittal view. Very well. And then, but generally, before even we go there, now in the CT it comes in different windowing. If you remember, we had a CT description which said what that windowing means. In some kind of graduation, you can see certain tissue the best. Generally, for CT, more or less, it's at the tissue window or bone window. So if you see the bone very well, then it's a bone window. Because if it wasn't a bone window, the whole bone would be white, and then you would see more graduation for soft tissue. So it's not a soft tissue window, it's a bone window. So CT of the lumbar spine in the bone window. Then you go to describe that there is a so-called sagittal view. And what is in the middle? What would you call that in the middle? Not sagittal.
The coronal view.
Coronal view, and then on this side, what is that called?
Sorry, I have to move the pictures over.
Yeah,
This is just a I just blinked on the name.
axial view. Now I know
Yes,
it's on the
axial
tip of
view.
your tongue. It's axial view. Now, what's important for CT is that the original picture is the axial view.
Mhm.
This one, coronal and the sagittal, we call it recon or reconstructions. What that means is that this is a real view. This and this on the side, they are based on the axial view, and the computer stack them and cut it in different direction. And that is a huge difference between the CT and MRI. In the MRI, you can get original coronal and sagittal views. In CT, you don't do that. That has the importance because how you interpret them and what you see there, what they mean, if they're real and so on. Literally in the CT, those axial views are made usually in the increments of 2.5 millimeter. Anything between, obviously here, you would see stacks, pixelated stacks. You don't see that because computer literally making things up for you. Okay, so if you see something on the axial and coronal view, and they don't say the same thing, they don't say the same story, always trust the axial view. Okay, so now we know patient X, the CT of the lumbar spine in bone window, in sagittal coronal, in the axial view and reconstruction, sagittal and coronal view. So let's start with things that should be easy for us. Christina, what is here? This dark here, what is this?
That's just air behind the patient.
Yes, very good. And so this density here, by the way, in the CT, you can measure that if there's a question, is the air density. There is something very dark, not quite as dark, but as well dark here. What is that?
I would say that's gas in the bowels.
Correct. And another thing, so let's say gas in the bowel, is that a normal thing?
Mhm.
Yes, it is.
Yes.
Where else is gas normal in our body?
Outside of the GI tract, are you saying?
Generally, in our body,
Mhm.
where would be normal to see gas? Like if I see something dark anywhere else, where would I be very worried about seeing the air in our body?
I wouldn't be worried if it was within the sinuses of the face, along the GI tract, or having darker densities within the lungs.
Yeah. Now, say let's identify where would be air normal to have. Anywhere beyond that would be a warning sign sign for infection.
Mm-hmm.
Because as you know, this anaerobic kind of infection, they take our tissue, they turn it into methane gas. That would be a warning sign. That would be a dangerous thing to see air in almost all tissue except few.
Mm-hmm.
So Neil, let's start with that. Where is it? Where would you see normal air in our body?
Normal air, most probably in any sinuses. So we know the sinuses
Correct.
in our face. You can definitely find air in our abdominal cavity. So
Yeah,
assuming-
within the GI tract, yeah.
within the GI tract. You can also probably find small pockets of air between joints. Is that where you get your popping sound from?
Let's come back to that.
Okay.
To that. Now, you mentioned two important places, our GI tract and our sinuses. There's another place that air is absolutely normal.
Mhm.
You know it. I'm just in our lungs and in our
Oh, yeah,
right.
yeah, of course.
So, Michael, this is now tricky, and that is related to what you and I are going to do.
Hmm.
Where else is air normal in the soft tissue. Within the soft tissue, absolutely normal to see
Mhm.
air, because usually that is not normal. What you and I will do in few months that introduce air inside of the body of the people.
At a surgical site.
Yes, you open it up, you do a surgery, air get in. How long is that air in the soft tissue normal?
I do not know.
Neil?
Is it a few days post-op you can have crepitus? Is that like a sign of air under the tissue?
Yeah, well, I wouldn't say few days, but for a day or so is normal.
Day or so.
Okay. Now, besides what we just discussed,
Mhm.
if you see air, meaning that you didn't do a procedure just in the last 24 hours, and it is not in one of those places we talked about, air is always abnormal. Even air in the joint is then abnormal.
Mm.
So why do we have air or dark sign inside of the disc here? You see that, right?
Yeah.
Now, first of all, we said it's not normal.
Mhm.
Is this patient having an infection? Why is that air in that location?
I wonder if there's damage to the disc that allowed air to enter.
Enter from where?
From surrounding soft tissues?
Why would surrounding soft tissue have air in them?
Right. Well, I know with infection, there can be air created from bacteria producing the gases.
Okay, that you're on the right path. Is there
Okay.
anything else? Do you think there's an infection there, or is there anything else that can create air from the tissue? Because there is no way air from outside or from our GI tract or anywhere else can get there if there wasn't a procedure. Like I didn't do a discogram, I didn't put a needle in this
Mhm.
patient and so on. Besides infection, do I need to be worried about infection, or is there any other way that air can be in the side of that disc or the joint?
Dr. Abbasi, did the patient have a history of wounds on the skin, like ulcers?
No,
Okay.
no. But you see that there are two ways to air to be created in our inside of our body. Three ways. You introduce it, either you breathe it in, or you swallow air, or the surgeon introduce it. A bacterial process or a mechanical process.
Mhm.
Literally, our body is made of proteins. The bacterial decomposition is not the only kind of decomposition that exists. There is so-called the mechanical decomposition. Literally, you put a protein, which is your cartilage, your disc material, between two bones, and those two bones, they hit each other all the time. The nitrogen from the protein of the cartilage get released. And if you sample that, people have done that. If you sample that dark gas inside, is mostly nitrogen from the protein that mechanically has decomposed. If there is anything like that inside of any joint, is not from those snapping things and so on, because that goes away right away. It is usually mechanical decomposition of the joint. Now, is it possible that the bacterial infection inside of the joint caused the same thing? Absolutely. But now I'm going to ask Michael, I'm going to ask you, if the patient come to you inside of the joint, let's say knee, you see dark signs, how would you distinguish if it's a mechanical or it's bacterial?
I mean, I would look at the patient first and see how they're doing, because if they had a raging osteomyelitis or septic arthritis of the spine, I would expect that they would not be very happy.
Yeah, it's a clinical infection causing gas is a massive infection sign. What are infection signs? Like if somebody has an infected knee, what are the signs? Do you guys say that those 3 R's?
Yes, the cardinal signs of infection.
Yeah, what are they?
So we have redness, so that would be erythema, We also have
Rubel.
swelling of the joint. We
Okay.
also have, I know the R's, I think the words are in Latin. So
Yeah,
I'm
they're
forgetting what
Latin.
all of those are. I know
Rubel.
we have
Rubel.
swelling, redness, pain, like sensitive to touch.
Yeah. And
Um,
warm.
one more.
Warm. It's warm.
Oh, and it's warm to touch, yes.
Swollen, warm, and painful.
Mhm.
Okay, these are the cardinal sign of infection. You should know that is one of the things. No matter what discipline you go to, you should be able to identify an infection.
Mhm.
Okay, so if this patient come to you, and then we have other clinical signs like fever, sign of sepsis, and then high white counts, and so on and so forth. If there's no sign of infection, and in a finding like that, you can as well see if it's an infection, the tissue surrounding it will swell up. Your body
Mhm.
wanna wall off the infection, but I don't see anything of that. I think we are very safe here to say this is a degenerative kind of air or nitrogen or gas accumulation inside of the disc. We have a specific name for that. Michael, do you know what we call it?
I don't.
Neil or Christina, do you know what we call this dork inside of a joint? We call it,
Crepitus, is that what you're asking?
no, crepitus is when the air is under the skin in the
Okay.
superficial tissue, because if you push on it, it makes
Mhm.
like you're pushing on some of those bubble wraps and
Mhm.
make that sound. That is where the word crepitus come from. But
Like dark, like you mean like what is air in a joint called?
yeah, if you read the radiology report or neurosurgery report,
Like pneumoarthrosis?
no, it is it is much less innovative than that.
Oh,
Call it gas sign or vacuum sign. Even though we know it's not vacuum,
mm.
just call it vacuum sign. Gas sign or vacuum sign.
Okay, yeah.
Okay, very, very simple. Now, look at this here in the middle picture. Do you see that there? Is that gas? Why is it so dark? Do I need to be worried that this patient is going to be septic? No, it is not. It is just the way we have windowed it. And if you haven't watched that, we made a video about how CT is created. I know people love to look at the pictures, but if you understand the language of CT, how it's created, you can make sense of it to much more than your peers.
Mm.
Please go watch that episode that we made about how CT is created, what windowing means. And so meaning that if I would just change the windowing, this would look like that. This is just somebody chose not a standard kind of windowing. That's why the fat here, they appear dark. Okay? So the fat or the omental fat look dark, but in a CT machine, you can actually go and measure it. So let's start looking at what we see here. We all agree that this white is the bone, and the edge of the bone is whiter because it's more dense. What do we call the edge of the bone, Christina? There are two parts to a bone. Every bone has two parts. A very hard part, which is outside, and we are very economic because if our body would feel everything with solid bone, we couldn't walk. We would be so heavy, we couldn't walk. Inside of the bone, there is a sponge-like material. And the sponge in Latin is called spongiosa. So there is a cortical bone outside, and there is a spongiosa part inside. That is why the edge of the bone are always going to be more dense. But I see as well something here. Are you able to see that I see something that has bone density right here? Christina, are you able to see that there is something that has?
Yes,
White
is that
bone
the abdominal aorta?
Yes. And what do you think what that is?
calcifications like atherosclerosis.
So we know this patient is, even if you don't know the age, we know this patient is not a young person.
Correct.
Because I hope you and Neil and Mike don't have this kind of thing in your aorta. I might have some of that, but you guys hopefully don't. So, and you see it here in aorta, but what is this? Right there. Who want to get a, you know,
Is,
if you say what it is, you get a chocolate. Exactly what is that structure? You get
Is-
it.
let me think, I don't know, renal artery?
Renal artery would be where? Where is our kidney? Just below the diaphragm, right?
Right,
Diaphragm is where? L1, L2.
okay, so we're too low.
And that would be as well, if it was a renal artery, it would be a renal artery of an elephant, because that's huge.
Hmm.
Would it be like an iliac artery?
You get a chocolate,
Oh, but
This
which
one
one,
iliac
internal or
artery.
external?
iliac.
Which one is it?
At this point, we are at L4-5. At
Mm.
L4-5, the aorta just split it. So it's a common iliac.
Okay,
It hasn't turned into,
hasn't turned into external
no,
either.
and that is why it's a horizontal. It's split and goes to both sides. That is why you see it in the sagittal view so well. Okay? So, and let's go here. What else do we see here? So you see these structures here. Christina, what are those structures I'm having the cursor on right now? What are they?
Are those the lamina of the vertebrae?
No, they wouldn't be lamina, because the lamina,
Oh, the transverse process, sorry.
very close. Everything that sticks out of a bone, we call it a process.
Mhm.
Okay? And the transverse process, by definition, they go transverse. They go to the side. But this is a midline cut.
So the spinous process.
Correct. That's the spinal process. Okay? So now, Mike, coming back to you. Do you see that the bone here, the back of the bones are in the same place? That is obviously normal. But when we come to L4-5, the back of the bones are not aligned. What is the name for that?
Spondylosis, or they have some like osteoarthritis.
Yes, no, but let's start with just that fact that the back of the bone are not aligned. What's the name for that?
Spondylolisthesis.
Spondylolisthesis, yes. You mentioned the word spondylosis. What is that?
So that's just kind of degenerative changes of the spine.
Do you see that the edge of the bone is growing out?
Mhm.
More or less, that's what spondylosis is. That the bone is under stress and it's growing in places it doesn't have to grow. Mostly that's at the edge of the disc. That's spondylosis. So now, is there anything else you see pathologic here, Neil, beside the spondylolisthesis, vacuum effect, spondylosis? Is there anything else pathologic you see there?
I guess some osteophytic changes,
Well, that is spondylosis.
but that's under the term because that can be any
Yeah.
degenerative change.
Yeah.
I guess I see right there, the distance between the vertebrae are a lot shorter than above.
Yes. And that is you're right. That is what we call that the disc is gone. The disc is a bad disc. What do we call that?
The degenerative disc disease?
Correct. Yes. So anything else that's wrong there? Christina, I'm going to just go with you over this. Do you see the curvature in the spine in the sagittal view?
Yes.
Is that normal or is it not normal?
I would say that
No wrong answer. Just go with
I
your
think
gut
it
feeling.
looks
Never double.
normal to me.
Never, doubt yourself. Just throw it out. This curvature, normal or not normal?
I
First,
would say normal.
normal. You're right.
Hmm.
We have a name for that. What do we call it?
Is that lumbar lordosis?
Correct. That we call that lumbar lordosis. Now, let's look at the front view. Do
Mhm.
you see that there is as well a curvature there?
Yes.
What do you think? Normal or not normal?
I would say abnormal for this.
Good. That's correct. Do we have a name for it? Yes. In medicine, we have a name for everything.
Mhm.
What do we call-
Scoliosis.
Scoliosis. Now, Michael, this is a more advanced question for you. If there's a question, we quantify it. How do we quantify a scoliosis?
You measure the Cobb angle.
What is a Cobb angle?
So it's the angle measured from the two. So you look at the top vertebrae and the bottom vertebrae when you can see the displacement, and then you draw an angle between them. and
Yeah.
measure the
What
curvature.
should it be? What should that Cobb angle be in this if it was normal?
Less than 15.
Well, actually, it should be 0. You should
Oh.
have no side bending in the spine in the front view.
Hmm.
Now, if it's a 15, you have a scoliosis with a Cobb angle of 15. In this case, yeah, I would say probably 15, 20 degree, and it is to the, obviously it's switched, right? This side is left, this side is right, so we have probably a Cobb angle of 15 degree to the left. Okay, now I'm going to ask you 2 more questions and then we move on. We spend a lot of time on this, but I think it was educational that, lots of basic stuff are the same everywhere you go. Do you see this here? Christina, do you see this?
Yes, I do.
This is a piece of bone, seems that just floating there. Is that correct? Almost look like it's floating, right?
Hmm.
So what do you think what that is?
Are those the ribs?
Correct. They are the ribs. Exactly. They are the ribs. Obviously, in a real person, it's not floating. It's just
Mhm.
that way. So let's go to the next picture. I think Neil's.
Yeah, Neil just said that he accidentally got kicked from the meeting, but he's trying to get back in it.
Okay, let's see if I can. Okay, I have it here. If he comes in, I made him host. Hopefully,
I think it put you back as host, Dr. Abbasi.
Oh, okay. Then if he comes back in, I can bring him back in. So,
Okay.
so Christine, what is this?
Yes. That is, I would say, an X-ray.
That's an X-ray. Yes. There's something special about this that you don't have to know. I have to know. This is not a regular X-ray. This is a different kind of X-ray. Mikey, why is it not a regular X-ray? And why do I know that it's not a regular X-ray?
It's a C-arm X-ray.
I would say it's even a little more than that. It is the machine that produced this was a very good machine. But it is a little different. It's a little grainy. Whatever machine produced that, it had detectors that has a certain size. That's why it looked a little different grain. So this is so-called Scout made when we get a CT. First, we use a CT like an X-ray machine, and then we identify what part of that volume we want to get the pictures. This is the so-called the Scout or the localizer of a CT. But for all practical purpose for you two, this is practically an X-ray. Okay. So, Christina, what CT or X-ray of what part of the body?
I would say abdomen and pelvis.
Abdomen and pelvis.
A coronal view.
Yeah. What do we call? Sometimes there's another name for when you get a CT that goes all the way from diaphragm to the pelvis. We have a name for that. Michael, do you know what it's called?
From the diaphragm to the pelvis? Is that
When you get an X-ray that includes everything below the diaphragm down to the pelvis, we have a name for that. I'm sure you have heard of that before. Have you heard the name KUB?
Oh yeah.
No? Would you
Kidney,
want to
ureter,
describe what that
bladder.
is?
Does it stand for kidney, ureter, bladder?
Yeah, that means kidney is just below the diaphragm, ureter, just the lower part, and bladder, the lowest part. So meaning that you get a picture that has everything in the abdomen below the diaphragm down to pelvis. So this looked like a KUB. If it was X-ray, it would be a KUB. So let me quickly stop sharing here, and then go to the next one. No, actually, let's stay with this. So now, Mike, what else do you see here in this X-ray or KUB? What do you see here?
I see some pretty clear instrumentation there.
Yeah, what are they called?
So I see two spacers, and then I see
The spacers here in the disc base.
Mhm.
There's a different name for that too. What else do we call these cages? Oh, sorry. So, well, yeah, we call them cages. Okay. And then, Christine, what are
Yes.
these right here?
Are those screws?
Yes, they are.
Okay.
They are
And
screws.
also, sorry, Neil's in the waiting room. If you could let him.
I'm admitting him. Okay. So the screws, and then what else do you see? There's a rod connecting the screws, right?
Yes.
Okay. Now, I'm going to go to different places and you tell me what they are, okay? Here,
Okay.
you see the hand?
Yes.
What is that? What anatomical structure is it?
Is that the descending colon?
Correct, good. Neil, what is this?
That is the transverse colon.
Excellent. And with that logic, Mike, what is this?
The ascending colon.
Yes, what is this?
The sigmoid colon?
Yes, excellent, excellent. And Neil, what is this?
So must that be descending colon?
No, here, look at that. We talked about the descending colon, and let me go to the other side. What is this? You see that there's a structure there?
Oh, are you pointing at the SI joint, sacroiliac
Correct. That is
joint?
the
Okay.
sacroiliac joint. What is, Christina, what is this?
Are you pointing towards the head of the femur?
Yeah, and the hip joint, yes. And obviously the iliac crest, right?
Mhm.
Oh my God, look at the iliac crest. Do you see how different they are?
Mm-hmm.
What is going on?
Is that just from the angle?
Correct.
Hmm,
Just they do not have to look symmetric.
they don't.
Yes.
Okay. I also know with patients with different Cobb angles, their pelvis tends to tilt one way to compensate too.
Yeah, but
Mhm.
you just change the angle. You put the patient on the bed and they turn a little
Hmm,
and they look totally different. So don't expect them to look the same.
okay.
Now I'm going to show you something here. Let's see here. What is that? That like a big blob of air. What is that?
Magenblas,
Yeah. Okay, what is that?
the stomach bubble.
Yeah,
I've never heard of Magenblas.
it's German. You know, the old anatomists, they were all German,
Hmm,
like Virchow, like Koch, and so on. Kocher, actually, it's
Mhm.
Kocher. All these names are German. And Magen in German means stomach.
okay.
And Blase means bladder, Magenblase. Or
So your stomach,
Americanized it to whatever you guys call it. But
yeah.
it's stomach. Okay. Okay. Next. Woo. That is a heavy one. Okay.
I tried to get some pretty interesting ones for you.
Yeah. Yeah. So number one, Christine, describe. What do you see? What kind of image is this? You know it now. By now you know it. Just tell me what it is.
Okay. So I would say that this is a CT of the thoracic spine
Very good.
at the sagittal view,
Sagittal view in what window? Tissue
the
window?
bone window.
Bone window. Good. Now you remember we start that. So what are these in the back? What are they?
Those are the spinous processes.
So it's a midline. When you see the spinal process, it's a midline cut.
Mhm.
This, you remember we said there are few places that air is normal.
Mhm.
Normal or abnormal?
Is that normal?
Yes. What is it? Big structure,
The
Air.
trachea is that?
trachea. Look at behind the trachea.
Mhm.
That there's something that has a line of air in it. What's that?
The esophagus?
Yes, esophagus, normal,
Mhm.
right? Okay.
Yes.
Okay. Now, here, what is that? Round, big structure right in front of the spine, right at where the trachea splits. Because the
Is
reason
that-
you don't see the trachea here is because it developed to the right and the left bronchus.
Is that part of the pancreas?
No, I would be very worried if pancreas was that location. Possible. If you have diaphragmatic hernia, like you have huge blunt trauma, and it pushes, it make a hole in your diaphragm, and it pushes all your organ into your chest. Okay,
Mhm.
but not in a regular person. So a very round, which is too big to be there at the pancreas, very round structure right below that bifurcation of trachea. What is that?
Is it the aorta?
Yes, it is the aorta where it comes and turns around
Mhm.
down, becomes ascending aorta. Okay, so obviously this is heart and so on. This here. Okay, Neil, show me your magic. What is this structure right here? You see that there? And look at that, that as well is part of it. This and this are part of the same thing. What are they?
I think, okay, so let me try to orient myself. I see the trachea. We're in the sagittal
It is
view.
way below heart. It is below the heart.
Is this the diaphragm? No, wait, liver.
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 Yes. It's
Once I
liver.
oriented myself with the sagittal view, then I just started cranking it.
Yeah. And if it was on the right side, it would be much bigger. But you're in the midline,
Mhm.
you see the lobes of the liver just about to go across the midline. Okay, liver is a
Mhm.
big organ. So, what about this picture makes a neurosurgeon nervous?
I'm noticing, is this kyphosis of the spine?
Well, I could measure the angle of the kyphosis.
A little bit.
No, kyphosis, Christina, what is kyphosis? I think you're muted.
Can you hear me now? Is the
What-
kyphosis like hunching of the upper back?
Yeah, no, the forward bending of the spine we call lordosis, the backward bending of the spine we call it kyphosis.
Mhm.
Mhm.
Kyphosis in the thoracic spine is normal. So
Would it be the calcification that looks like it's, I don't know if that's spondylosis kind of going within the spinal cord? Is that what you were
yes,
mentioning?
that makes me
Mhm.
very nervous. Here, you see that this
Yes.
is what you mean,
Oh.
right?
Yeah,
Yes, that's what I meant.
good catch,
Yeah.
Christina.
That makes me very, very nervous. Why?
Because it
gonna
could
be-
be
oh, sorry.
protruding. Sorry.
No,
No,
go,
it's good. You go for it. You got it right. Keep going.
Yeah, go. Go, Christina.
Because
Why
it could
would
be
that make
protruding into the spinal cord and could
the
cause
spinal
damage to the
canal? We
nerve.
call it spinal canal.
Yes.
That is the spinal canal,
Mhm.
and there is a piece of bone sticking out into the spinal canal. But again, let's come back to that. Why does it make me nervous?
They could be like myelopathic. They could get a permanent spinal cord injury, permanent nerve damage, paralysis.
Yes, all of that. No, myelopathic. It can cause myelopathy. And myelopathy is a bad thing. Neil, can you describe to us what myelopathy is?
Well, I know we have. So if this is going to be impinging on the spinal canal, so is this just a broad term to cover spinal cord damage or spinal cord disorders?
No, it is a myelopathy is a very distinct kind of situation. Now,
Is this similar to neuropathy?
neuropathy is a yet different kind of thing. We can go over that nomenclature. I think all of that is important. Now, how does your brain communicate with your peripheral, with your muscle? How does it communicate with it?
It communicates. So we have our central nervous system. The brain is connected to the spinal cord. And then
how many neurons are they? How many neurons does it take for you to flex your tibialis anterior? How many neurons?
Well, I guess from what level, if we go from the level right
From
there,
the cortex, from the cortex down to your tibialis anterior muscle.
so the cortical spinal tract is going to come down.
Yes, but how many neurons do you need to give your tibialis anterior the command to contract? Two.
I was going to
that's
say
all it
3,
takes.
2 or 3. Okay.
One goes, the cell is in
Yep.
almost in your brain, and it
So
goes
now-
all
is
the
it-
way through the tracts, but it's
Mhm.
still one neuron. It's axon. Its axon is a humongous long axon.
And does it decussate in the medulla? And that's where it synapses, and then it goes down?
Well, it's still the same neuron, the same axon. It goes through entire path, the cortical, spinal tract, and so on, and it comes down to the segment, and then it connects to the second motor neuron.
That's where okay. I think I was also thinking of the sensory. So at first, when you sense a stimulus, then it goes up to the spinal cortical and then crosses medulla.
Yeah,
And you think of what
that
you
as
want
well
to
is
do.
two neurons. That as well is two neurons, but
Okay.
but I think as a neurosurgeon, I'm more nervous about the motor than
Mhm.
the sensory,
Right.
because motor is if you lose motor, it's much more devastating than if you lose sensory.
Right.
Okay, so let's talk about the motor neurons, the first motor neuron and the second motor neuron. Like when you're a baby, your L1 cord, where the nerve cell for the second motor neuron is at L1.
Mhm.
Your L5 nerve is at L5. But when we grow up, like our age,
Mhm.
bone grows faster than spinal cord. So it retracts. Literally, the nerve cell for our L5 and S1 are at higher level than L5 and S1 in an adult. They are at what level? Mike, do you know that?
What was that? Sorry, I was looking
So
up.
the nerve cell for the L5 and S1 in an adult, in a baby, nerve cells of the L5 are in L5, the nerve cells of the S1 are at S1, but in our age, the nerve cell of L5 and S1 are at what level?
Is it like L1, L2?
Correct, and that we call,
The cauda equina.
we call that conus.
Conus
Medullaris?
Medullaris. Conus medullaris.
And isn't there a pathology when the stretching or the growth is going too fast for the cord? Is that tethered cord syndrome?
That is exactly what it is. And see, below the conus, it's cauda equina, which is the tail of a horse. Okay. Now, it's mostly nerve cell, the peripheral nerves almost. But sometimes there is a band of tissue that's still holding the conus back. And that pulling on the conus can cause problem. We call that tethered cord. Then we go there and we cut it. Neurosurgeon go and cut it. But so
is there a name to that band of tissue? Is that the ligamentum flavum?
no, it's not the ligamentum flavum. Ligamentum flavum, if you look at the anatomy, is the part of the ligament that connect one lamina to the next. Okay, so let's come back to that. We were talking about that this picture makes me nervous, and we're talking why this makes me nervous. So
because myelopathy.
Because of the myelopathy. And what is the myelopathy?
So myelopathy, you are worried about the motor neuron that is leaving that
First-
level to control the muscle group.
Myelopathy is the damage to the first motor neuron.
First motor neuron.
And it's first of all, it's important because it's like a cascade effect. It affects lots of different things, not like a peripheral nerve that affect only one muscle group. It affects lots of things below it. And secondly, these are nerve cells that are being damaged. So a damage, if it continues, it's irreversible.
Right.
So a myelopathy should make every person nervous. And there are two kinds of myelopathies. There is a radiographical myelopathy and there's a clinical myelopathy. Clinical myelopathy is the damage to the first motor neuron. What are the signs of the myelopathy, Mike? What are the signs of myelopathy?
You can get like hyperreflexia,
Hyperreflexia, correct?
abnormal Babinski sign. You can get
Pathological reflexes. We bunch them together on the pathological reflexes, including Babinski, okay?
clonus.
Yes.
They can get just deficits in general of those muscles.
Proprioception, balance, extremely important. Okay, these people can, if they don't look at where they are walking, they cannot walk because they don't have any proprioception, which is a position of the joint. They have to compensate for that with visual clues. Okay, so that is what it makes me. There's a piece of bone, by the way, that is a part of disc, and that this patient wasn't doing super bad because this was a part of this that over the years was doing that. If something like that happens, like, after accident right away, this patient would be most likely paralyzed. But if it happens over years, it's amazing how much our spine and spinal cord can compensate. So, what are these here? These are the same as down here, but they are not as severe and not as
Osteophytes.
progressed. Yes, exactly. The content of the disc turning into bone. This is calcified disc or osteophyte. So let's go to the neck. Let's look at a few more things. Oh, here we go. Okay, Christine,
Wow.
what do you see there?
Okay, can you guys hear me?
Yes.
So Dr. Vasi, you just want me to describe the image? Is that
Right.
correct?
First of all, what kind of images are we looking at?
Okay, so this is this a T2 CT or a T2?
Now, T2 would be MRI. First of all, is it MRI or CT? And I give you one better. Why does this CT look like an MRI? You're on the right path. Your brain is on the right place. This could
I
be T2
initially
because
thought that
CSF looks
because
white. You're going the right direction. This looks like an MRI because the CSF looks white.
yes.
That would be a T2, but it is not.
Yeah.
So what is it?
So then it would have to be a CT.
No, it is a CT, but why does CSF that usually
Because
dark?
of contrast.
Exactly. If you put contrast in the CSF space, what do we call that study?
Myelography.
Myelogram, correct. And this is obviously a post-myelo CT. So describe again what you see. What kind of image, what do you see?
Okay, so this is a CT with contrast of the cervical and thoracic spine.
I wouldn't see the entire cervical spine, so I wouldn't call
Okay.
it the cervical.
Okay, so just thoracic spine from a
Yes.
sagittal view in the bone window.
Correct. A post-myelogram CT of the actually entire chest. I think Mike cut a little off, so it's not only spine. So it's a post-myelo CT of the chest in a sagittal view. Now, let's go easy parts. What is this?
The trachea,
Trachea. What is this?
the stomach.
Stomach. Correct. Very good. And those dots you see, they are the esophagus. Okay.
Mhm.
Now, I'm a little concerned about this thing in the front. What is that? Wow, there's air underneath sternum? What is going on? Mike, what's going on there?
Is that a portion of their lung?
Yes, bingo.
Mhm.
Okay, bingo. It's a portion of the lung because obviously the lung is just turned around and feels every gap that's out there. Okay. Now, what is this here? What is going on here? Right there.
Is that some like calcification of the pulmonary vasculature?
It could be, but something like that, I would go to the original window in the axial. I would correlate them to see
Mhm.
what it is.
Is that like a cardiac device or something?
It could. I doubt it's cardiac device because it is not, it doesn't seem to be a solid metal. But
Mhm.
again,
Yes.
I would never make a determination of what it is just based on that. I would go to other views and correlate, look at different views, and
Right.
then make a decision.
I actually have a follow-up question about the last
Yes.
one we were on. I was wondering how that patient would present clinically.
This
The
one,
the one with the potential myelopathy. Let's see.
this one.
Yep, that's the one.
So you want to know how this patient presented.
Because I was trying to figure out like the
This
level.
patient,
where
this
three-
patient had lots of back pain, lots of radiculopathy, and starting myelopathy.
And would those be lower motor neuron symptoms?
Myelopathy is always upper motor neuron.
Always up there.
Yes.
Okay.
The lower motor neuron is segmental weakness,
Mhm.
claudication, neurogenic, obviously, claudication, and
Mhm.
sensory deficit. No hyporeflexia, not hyperreflexia,
Mhm.
no clonus. Usually no problem with the proprioception or balance because it is segmental weakness.
Mhm.
Okay?
And
Thank
it
you.
looks
You
like-
clarified that very well.
It looks like that was at like the T9 level-ish.
Yeah, but to say that, you have to go back and forth, count the ribs and so on. Don't ever try to get more information from a picture than it can really give you.
Mhm.
Like, don't try to identify what this is just based on this picture. Look at more pictures. Like here, what is this? Mike, what is this?
The scapula.
Scapula. And obviously, these are the lungs.
Mhm.
And you see those dots and so on inside of the lung. What are they?
Parts of
Oh.
like the bronchioles and stuff.
No, bronchus would be air. You wouldn't see that. It's something that's more dense than air.
Is it the cartilaginous rings of the
No. What is more dense? What is the densest thing in our lung? You know that
is that
fluid. It's kind
the
of
fluid in the fluid filled sacs?
No. What kind of fluid is normal to be in the lung? You know, your blood is a fluid, right?
Oh, yes.
Okay. These are the bronchial, the lung vessels,
Mm.
arteries and veins. Generally, arteries are round
Mhm.
and veins are more flat or oval.
Mhm.
Okay? Okay, here. Now, Mike, you describe what you see.
Okay, so this looks like a CT to me, and I'm looking at the left one first. So that's a sagittal CT
Okay.
of the lumbar region.
Is there regular CT or is there
I can see the spinal cord super well, so it looks like a myelogram to me.
the postmyelogram CT of the lumbar spine in sagittal view? Good. So describe, let's go here. What is this here? Right here. Are you
That's
able to
just-
see it?
Yeah, it looks like just like soft tissue of the back, maybe a mix of like subcutaneous and muscle tissue.
No, it is just the subcutaneous fat.
Mm.
Okay.
The muscle look more like this.
Okay.
But this is just the subcutaneous fat. And here, same thing. This is the omental fat. So then here we see what?
The spinous processes,
And the ligament between them.
the ligamentum flavum.
No, flavum would be lower.
Okay.
Flavum would be somewhere here on this picture here. The flavum would be here. This is just an interspinal ligament.
And is the ligamentum flavum, is that on the inside? So it would be facing, like hugging the spinal cord?
Let me unshare my screen and get my my model, and then I can explain it to you maybe better. This is the spine of a deer,
Mhm.
okay? And the ligamentum flavum goes from one lamina to another. As a matter of fact, it goes from the top of this to underneath of the next above lamina.
Mm.
And it sort of completes the tubeness of the spine. Okay, wherever there is no bone, there is ligamentum flavum to keep the spinal canal a full kind of tube.
Mm.
And the interspinal process is here.
Okay.
These are two distinct things.
How
So-
many mammalian spines do you have?
Say one more time.
How many spines do you have of different
Oh.
animals?
Well, I haven't studied all of them, but
Hmm.
in most of animals, they have more vertebrae than
Hmm.
human. So, like pigs have almost like 5 to 7 lumbar vertebrae, and
Hmm.
about 14 or so. We published a paper about the pig anatomy, which is the closest to human, by the way.
Hmm.
We can talk about it another time. But in human, we usually have 5 lumbar vertebrae, but about 10% of the people can have 1 extra.
Hmm.
Okay? So, Mike, now let's go. Tell me about what is not right about this picture.
So it looks like there's some damage that would maybe be consistent with like a compression fracture at about, what is that, ELF2?
And
And then I can see this radio opacity back here, and I'm not quite sure what that is.
now, well, let's start with, you have a compression fracture of L5, 4, 3, 2, and L1, correct?
Yep.
You see them both. How do we express a compression fracture? We express it in the percentage of the fracture. We measure the level above and below and see how much it is. And here I would say is probably at the lowest level, about 50%. And here's probably 70% compression fracture, 50% compression fracture of L1 and 70% compression fracture of L2. And there is a osteophytic fracture as well there. But I can tell you this is not new. This has been there for a while. How do I know this has been there for a while and it's not new? I know it because look at the edge of the bone. The edge of the bone has turned into cortical bone. A fresh fracture, the edge of the bone is not thick, it's not dense. Whereas an old fracture, the edge of the bone is corticalized and becomes thicker. And that's the way our bone heals. You're right, there is a cage here in L5S1. And if you look carefully, you as well see the screws, 4 screws. Patient had a previous L5S1 fusion. And there is a spondylolisthesis in L5S1. And if you look carefully, there's a little bit of a spondylolisthesis in L1, L2 as well. You see the back of the bones are not aligned. So now, Neil, what is this?
If I'm correct, this looks like
Upper lumbar spine, below the diaphragm.
so,
Nice
no
kidneys. Yes, they're the
kidneys, right? Yeah.
Yeah, they are kidneys. again, you remember? Look at that. This kidney has something inside. What is that?
Yeah, is that the renal pelvis or the?
Yeah, it's where everything get collected.
Mhm.
The other one doesn't have it. Oh my God, what's going on?
Oh, I think that's just the window. We
Yes.
might not be deep enough
No,
for
it's
the
not.
level we're at.
It's just the cut is not through that segment of the kidney. It's
Oh
just-
yeah, just like when we were talking about the pelvis earlier, that could be one
Exactly.
reason.
They do
you know?
not have to look symmetric.
Mhm.
Do not look for symmetry in a CT because just you change the angle just a touch and it look completely different. Okay? So
Mhm.
do you see now here the cauda equina here?
Yes.
You see those lines that are going down? And if you look carefully here, because this patient has a lordosis, this coronal cut won't be into entire canal. So it is 5 o'clock. We are going to call it a day. I
Wow.
think we learned a lot of things. It really time went fast. I really enjoyed that.
Yeah.
One
Thank you
last
so
thing.
much. We learned a lot.
Yeah. Christina, one last thing for you.
Yes.
What is this here?
Um,
You see that? This is the kidney.
yeah,
And
are
this is
those,
the spine and ellipsoas muscle starting.
yeah,
But there is a layer of something that is not very dense between the kidney and the rest of the tissue, something that goes around the kidney. Do you know what that is?
if
Has-
I had to guess, I would say like the iliac.
No, look at that. It's the same density like
Oh,
under the skin. It has the same density almost that the tissues that under the skin.
just adipose tissue?
Yes, our body is a miraculous thing. It envelops all our important organs in a layer of fat.
Mhm.
Okay? Literally, when you go there, there's fat tissue around our kidney,
Mhm.
protected. Okay? So,
Okay.
okay, let's call
Thank
it a day.
you.
Okay?
Wow.
So, guys,
Thank you so much.
it was great having you guys and everybody home. If you have questions, submit it to Neil.
Mhm.
And otherwise, we see you in 2 weeks. Okay?
Sounds
Bye.
good.
Okay.
you so much.
Everybody. Bye.